Welcome to Around the Room, brought to you by the Canadian Rheumatology Association. This episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Morphology in the clinic overrides everything, including the history, timeline, locations on the body, etc. What we really need to know is what the primary lesion is of any skin eruption.
Just taking a step back, in rheumatology, we are mostly lumpers. We like to lump everything in a beautiful diagnosis. And I've learned in dermatology, they're splitters. They say, oh, you have 4 different skin problems.
That's Dr. Kam Shojania. And Dr. Sheila Au. Dr. Shojania is a clinical professor at the University of British Columbia. He is also head of rheumatology at Vancouver General Hospital and medical director of the Mary Pack Arthritis Program. Dr. Sheila Au is a clinical professor in the Department of Dermatology and Skin Science at UBC and a medical dermatologist at St. Paul's Hospital. Together, they run the Dermatology and Rheumatology, or DART, clinic at St. Paul's Hospital. We're thrilled to have them as our guest to talk about rheumatology and dermatology here on Around the Room. Welcome, everyone. I'm Daniel Ennis, and a warm welcome to my fellow co-host, Dr. Janet Pope. How are you?
Great. And how are you, Daniel, in 2026?
I'm not so bad. I'm doing pretty good. And how's your bird doing? We were just getting some sound in the background.
James, the bird, is going strong. He almost has a rheumatology fellowship.
I bet. You know what? All the talking about rheumatology you do, I bet James has lots to say. Okay, enough fun stuff. Time to get down to business here. So, Kam and Sheila, thank you both for coming on the podcast and welcome.
Nice to see you too.
I'm so happy to be here.
That's great. You're both at UBC, and I did part of my training here. And as a trainee, I got to work in the DART clinic, the rheumatology-dermatology clinic, and got to see how well you two work together. Could you just tell us how you met and how the clinic got started?
We met in 2011, 2012, when Sheila was head of dermatology at St. Paul's and I was head of rheumatology. After one of the meetings, our Department of Medicine meeting, we just started talking about it. I think I asked Sheila if she wanted to do a derm room clinic, and you thought it was a good idea.
Yeah, I thought it was a great idea. And it was so spontaneous and so novel. And literally the next week I came in and met your office staff and who were amazing. And we looked at the space. We talked about the types of conditions that we see, where combined clinic would be of value, where that combined overlap of expertise could be of value to patients. And then we just went for it. There were a few little infrastructure things that we had to make happen with regard to minimal supplies that we needed to have a dermatology clinic. But really all it took was a rheumatologist, a dermatologist, space, time, and the interest.
So you said that you instantly thought it was a good idea. And now, having worked with Kam for so long, do you still think it was a good idea?
That still remains to be seen. I ask myself that every week. No, it's been such a fantastic collaboration. I think we both agree it's just one of our favorite things that we do professionally. And it's evolved so much over the past 14 years as we've learned about so many aspects of this in terms of teaching, how we work the best together, how we manage the control chaos of the clinic, and how we can do our best for everybody who's involved.
I learn every week something new. All these years, there's something I learn every week. And I'm to the point where I know what I don't know.
Kam, so me and Kam also share an office together, so I get to see Kam after he's had DART clinic, and I can tell you, on the days when he doesn't have DART clinic, so when Tuesdays are booked just general rheumatology, the guy's miserable. He just wants to be there at the DART clinic with you, Sheila. And on Wednesdays, after he's had a great DART clinic, he talks to me about what interesting stuff he saw. It's obvious to me how much he enjoys sharing that clinic with you and how much he gets out of it. Before we jump into more specific topics, I wanted to get a brief review of morphology. So I know I learned about it in med school, and I stumbled my way through it in residency. and I try my best as a staff. But could you remind us about what morphology is and how we're supposed to describe it?
Absolutely. So, morphology is the language of dermatology. And it's the language of dermatology because it's what we base our diagnoses on. So, we don't base our diagnoses on where on the body a skin eruption is, or whether it's when it happened, if it came on suddenly, if it came on gradually. All of those things are helpful after the fact. But what we really need to know is what the primary lesion is of any skin eruption. And there are a few primary lesions to know about. And once you've decided what the primary lesion is, you can put all the other pieces of the puzzle together to narrow the differential. Our differential diagnoses are based upon the primary lesion. And the primary lesions in dermatology include a macule and its larger correspond the patch, the papule and the plaque, vesicle and bulla, nodule and tumor. Those really are the primary lesions. The secondary lesions, that is, lesions that can help to describe what we're seeing but are not the primary lesions, are things like scale, crust, an ulcer, or erosion. So we can't really make a diagnosis based upon crusted erosion. Those are not primary lesions. So we would need to know if something is an ulcerated nodule or a crusted papule. And so it forces us to look at the skin in that context. And that is so valuable because once you know what the primary lesion is, then we can go to our textbooks and all our references to find differential diagnoses because the differentials are based upon the primary lesions. And so as Kam knows, morphology in the clinic overrides everything, including the history, timeline, locations on the body, etc.
I think that's interesting because I know in some centers, dermatology branches off of internal, or that's another way to approach dermatology. You can do it as fellowship after internal medicine. But we're taught like history is king. If you haven't solved the case yet, the history is what you go back to, but also physical exam. And I think that you're making the point that at least for dermatology, that physical exam it's so essential to properly label what is happening, what you're seeing to figure out a diagnosis. And maybe that's what history is to internal medicine. It's trying to figure out the time-ordered sequence, right? The conclusive history of what happened is how we make diagnoses. So I think that's an interesting difference between dermatology and internal.
And I think many of, like myself included, and our trainees, that we just call everything, if in doubt, it's macular papular, and we send it. But obviously, I realize that there's holes in that kind of way of thinking. It's because sometimes there's big red raised and little red raised areas. That's, I think, my default. And then, of course, we love to talk about scale or not, pyoderma gangrenosum, the crater or not, and things like that. So I think it's going back to first principles and maybe in many ways reteaching myself and helping to reframe the trainees would be really helpful.
When in our clinic, when the residents first start, the rheumatology residents, I say them, I tell them whatever you say, don't say maculopapular to Dr. Au.
Yeah.
Yes. Oh my God. My pet peeves are already being revealed.
Yes.
It's true because actually, if we really look at something that's maculopapular, you'll probably find, Janet, just as you said, that it's actually more plaques than macules. And remember, a macule is flat and a plaque is raised. So something can't be both a macule and a papule. And so just looking back, just taking a step back and deciding on the primary lesion, it's one of the hardest things to do. And it takes a whole dermatology residency to become a morphologist and then a whole career because I do think that we're always constantly surprised and we have atypical presentations where the morphology isn't classic, etc. But it's still a challenge for us. So I can see how it can be a challenge for rheumatologists for sure. But rheumatologists are very good at looking, very good at noticing, and very good at analyzing. And I think all of those three things make you well positioned to make dermatologic diagnoses. And if you can't make the diagnosis because there's 4,000 skin diseases, and if you can at least describe an eruption with the primary lesion being accurate, then anyone you speak to in dermatology will be able to help because the primary lesions are right there. And we always tell the residents that when we're examining a patient or when we're thinking about a skin eruption, Richard Crawford, who's one of my mentors, who's a dermatopathologist and dermatologist, talks about the 4 things to talk about in your physical exam. And one of them is, okay, the broad location on the body, because that helps us to create a picture of anatomically where the eruption is. That is definitely a necessity, and we're trying to be as accurate as possible. So the anterior hairline or the medial cheeks or the distal dorsal hands, the accuracy and location, whether something is symmetric or asymmetric. So things that are asymmetric can often be exogenous, and that are symmetric can often be endogenous. And although that's not a hard and fast rule, in dermatology, you can think about someone having a contact dermatitis that may just be on one arm versus someone who has small vessel vasculitis, which is primarily bilateral. It's more endogenous.
Mm.
Then there's configuration, and we talk about this a lot, right, Kam, in the clinic. We talk about how the lesions relate to each other. And we're still pretty far back when we're looking at this. We're not staring really close at just the one spot. We're looking at the topography. And that can help us to
And Sheila, would that be the spaces in between the lesions then? Looking at its space in between and that, oh, it's very distinct, like erythema multiforme, there's not a lot happening in between the lesions.
Exactly. So configuration would be, are these lesions discrete? Meaning they're all there, scattered and separate from each other, or are they coalescing? And when we talk about this in the clinic with regard to, say, eczematous dermatitis, where the papules are ill-defined and coalescing, versus psoriasis, where the lesions are very well defined, and they may coalesce together, but they're very sharply defined. And then the distance between lesions, we have follicular and non-follicular eruptions, for example. Follicular eruptions are very regularly spaced because they're associated with hair follicles. There's always the same space between them. Something that's non-follicular, the lesions can be touching each other, they can be far away from each other, and there's no regularity to that.
So I think that's good background then as a jumping off point to maybe talk about some specific issues that rheumatologists need to know. So we're really going to talk about or focus on clinical pearls of a couple different topics. So maybe we can start with alopecia. And perhaps I'd love to hear Kam's take because tons of lupus in your practice. And I'm really curious if you can frame this for us. Like, what does a rheumatologist need to know about alopecia?
I'm embarrassed because before I was working with Sheila, I really had a rudimentary idea of alopecia and lupus. And I thought, oh, well, if someone has lupus and they have alopecia, the alopecia is part of the lupus, obviously. And now I realize that for the most part, that's wrong. There's many different types of alopecia, and I've learned scarring and non-scarring and lupus related or non-rheumatic related alopecia and how and the other thing I learned from Sheila and working in the Dart Clinic is how important alopecia was to someone's life. As before, I would think, oh, it's just hair. And now I realize how important it is to people's quality of life.
As someone reaching an age where I may start losing hair, I totally get that would be a really big deal to me, even if it's not, I'm joking around, but I think non-life-threatening symptoms may have major quality of life implications, and significant alopecia is a problem. Sheila, can you hone down on that a little bit? Tell me about alopecia. Maybe we use lupus as a jumping off point, but why is alopecia in a lupus patient not necessarily related to the lupus?
Okay, absolutely. And echo everything that Con says. Alopecia is extremely bothersome to patients, to men and women alike. Alopecia of the scalp, we have patients who have alopecia of the beard, alopecia in other parts of the body. I think that more people than we even recognize in a rheumatology practice have hair issues and hair concerns because there are so many reasons why you've got a large predominance of women in your practices. Women can have hair loss for so many reasons at different phases of life, and many of these conditions we see more in women than men, but we also see them in men as well. I think the approach for rheumatologists is this something that is going to scar and destroy hair? Is it scarring? Or is this something that is still very upsetting to the patient, devastating potentially, but is it non-scarring? With non-scarring alopecia, the hair follicles are not permanently destroyed. And so in that sense, we might have the benefit of a bit more time, and we also have benefit of reassurance, and obviously completely different treatments really for scarring and non-scarring alopecia. So I think that's the first thing. If people complain of hair loss, we're thinking in our minds, okay, scarring or non-scarring. The other thing, is it localized or generalized? Is it patchy? Is there a pattern to it, or is it all over? So those are the questions that we're thinking of. Are these spots, is it a spot that's been expanding over years, that's tender, itchy, that's erythematous and scaly, and no treatments have worked? Or is this something that happened abruptly where there's intense shedding?
And maybe you can articulate that. So, how do you distinguish scarring and non scarring alopecia clinically?
Yeah. So the physical exam is going to be essential here. So thinking about the scalp, you're looking at the area of alopecia. So you want to examine the entire scalp. There might be areas that the patient cannot see, and we discover. And as I said in the very beginning, you're looking for patterns. But really, when you look at the patches of alopecia, what do they look like? Can you see the follicular orifices? So hair follicles are spaced apart in their little tiny orifices where you can see little hair pieces of hair coming out. And let's, for example, take something like alopecia areata, which is an autoimmune non-scarring alopecia where you get these alopecic hairless patches or partially hairless patches. The hair follicles, not all of them may have a hair in them that's coming out. Some of the hairs may be broken off because the hairs are sick, but you can actually see the little orifices and you can get your dermatoscope out and look for those. If you see them nice and regularly spaced, that's very encouraging. But if you see hair follicles that are different distances apart and several millimeters of space where there's no hair follicle, because sometimes it's just 2, 3, or 4 millimeters, where you see these patchy areas where it's just shining and atrophic and maybe tight and homogeneous without any little follicular openings, that's a sign of scarring alopecia. And we've all seen full-blown scarring alopecia, for example, in discoid lupus, where it's very irregular in shape and hypopigmented and hyperpigmented and scarred. And it's a no-brainer. We know that this is discoid lupus. They may have discoid on their face and their ears. Early scarring alopecia can be more subtle than that and have just small little areas that have no hair. The other thing to look for are areas of redness, scale, and follicular keratoses. So scale at the hair follicle, like perifollicular scale, they call it. And those can be signs of scarring alopecia like discoid lupus or lichen planopilaris, which are two of probably the most common types of scarring alopecia that you'll see as a rheumatologist.
May I add that she also taught me about the color of the scalp, and because scalp should be very pale, and the alopecia areata has a tone that has
Yeah,
shown.
it's got this sort of salmon colored or pinkish hue. And some of the other scarring alopecias have erythema and associated burning and discomfort.
And Janet, tons of lupus. What do you do about your patients who come in with alopecia areata? They have lupus, but they also have alopecia areata. Do you deal with that as a lupus feature, or do you say this is almost like having thyroid disease, right? You have lupus, but you're at risk for other autoimmune diseases. And it's seen more commonly in lupus, but it's not a disease-defining entity. This is separate. I'm curious how you frame that in your
Right.
head.
Right. And that's an excellent question because obviously alopecia areata is an autoimmune disease. mostly self-limited, but can recur later and can be very distressing. And although I would know how, I wouldn't do it as well as the derms for trying steroid injections around the edge with very diluted steroids, I learned, so that I don't give atrophy in their scalp. I had to learn that after doing it the wrong way once or twice. But what now, there isn't an approval right now for a drug that will treat alopecia areata and lupus. Unfortunately, baricitinib, which does seem to treat alopecia areata and has approval in some countries, didn't go far. Their phase 3 trial in lupus was negative, unfortunately. However, while trials were going on where we didn't know the phase 3 was negative, I have tried every JAK, 100% off label, just to admit, because unfortunately, I also see people who have discoid lupus and scarring on their face, on their scalp, who also then you go, this looks like alopecia areata as well. What's going on? And they'll say, yeah, my mom started having those patches as well, and hers grew back. It's, oh, that's so unfortunate. But on some of those people in desperation, off label, I have tried all the JAKs that are in my cupboard with some degree of success. But alopecia areata, I could probably do nothing and they'd have success. And Sheila, you'd probably agree that over time will win for alopecia areata. Time does not win for discoid lupus.
Mm.
Correct. Yeah. Yeah. I agree. I think you make some really great points here with regard to the treatment of alopecia areata. Specifically, if we just talk about local treatment, I think you probably did your patients a great service by injecting them with steroid, and you probably used very, even if you develop atrophy, I find is very forgiving. The scalp's very forgiving, that even the divots of atrophy, which we warn all patients about, even if we're using 2.5 mg per mil, which is typically what we're using now for alopecia injections in general. We don't tend to get much atrophy with 2.5 mg per mil. We always warn that it can happen, but luckily the atrophy in the scalp is quite reversible. So I'm sure you've done really well with that. And I always joke with the patients about scalp injections and biopsies and other things we do as dermatologists, because compared to what you do as rheumatologists, I say, I've seen Kam inject the tiniest little joint in the tiniest little digit. Our procedures are definitely things that rheumatologists can do and do well.
Calm. I don't practice like Janet Pope does. Should rheumatologists be doing steroid injections on alopecia areata? I know Janet can because she's Janet, but is this sort of a skill that we should
Our
like? Do
residents
you
are
do that?
learning them.
That's great.
Our residents are learning these skills. Alec Yu has been on the show. He did some injections, and lots of them are coming through and doing their. I think it's perfectly reasonable to do. And Dr. Au also does a hair pull test to see if it's active on the edge. And I think you're more likely to inject if it's active, right?
That's it. If we see erythema, if we see a positive hair pull, if we see if the patient reports that the lesions are expanding, sometimes they are a little bit symptomatic, then we don't hesitate to inject. And then the next time they come in, you see these little tufts of hair regrowing in areas that we've injected, and that's really encouraging. And I think that when you're injecting for alopecia areata, you're going into the deep dermis. There's a real feel for it where it's not too easy and not too difficult to inject. And we inject a few millimeters apart to cover the patch. And because we're using such a diluted Kenalog, or sorry, triamcinolone acetamide, we can actually cover a lot of ground as well. And I think that in areas where dermatologists are in really short supply, it's definitely a skill that a rheumatologist could consider acquiring and helping their patients out for limited patches.
Yeah. I'm curious. So you've given us lichen planopilaris, discoid lupus as our major scarring disorders. We covered alopecia areata. Could you just rhyme off for us, like, what are the other major things that rheumatologists might get wrong in terms of diagnosing lupus-related hair loss or rheumatic disease-related hair loss, just so that we round out our list?
Or unrelated,
Yeah,
the
yeah.
the male pattern changes in women, etc.
Totally. And the biggest one, I think, is telogen effluvium.
Tell me about that. Yeah, how do we figure that out on physical exam?
Timing, yeah, we were saying how history is less important, but I think with telogen effluvium, history helps a little bit because if they had a severe lupus flare a few months ago, or just delivered a baby a few months ago, or another major illness a few months later, When Jen has got them on their immunosuppressives and they start losing hair, they'll say, Dr. Pope, I'm losing my hair because of your medication, but it may be the telogen effluvium kicking in from their illness.
Hmm.
Exactly. So we typically see after this sort of insult, whatever it is, and it may be a flare of underlying disease, etc. We'll see that shedding 3 to 4 months later. And then typically it stabilizes and the hair regrows, but it takes time. And that is the hard part, is it takes time. And sometimes early female pattern hair loss can mimic telogen effluvium, and sometimes they coexist. And so then it's about following the patient over time to see which direction they're going in terms of the hair thinning. But that big shed where the ponytail is thinner, there's so much hair in the shower, on the floor, in the sink, it's really stressful for patients. When we have global shedding like that, one of the things to think about is this diffuse alopecia areata or telogen effluvium. And diffuse alopecia areata usually is associated with little alopecic patches if you really look. And we don't see that with telogen effluvium. It's much more kind of global. And then with alopecia areata, you may lose hair in other parts of the body, like the eyelashes, the eyebrows, the rest of the body, which wouldn't happen in telogen effluvium. And with telogen effluvium, you rarely lose more than 30% of the scalp hair, which in alopecia areata, as we know, we can lose the entire scalp hair, and that would not happen in telogen effluvium.
Interestingly, that sounds like you were differentiating alopecia areata from telogen effluvium, if I'm understanding, less based on the morphology and more based on more distribution over the body, historical features, some of the other components of kind of your dermatology tool set. Is that right? Or does the morphology actually look substantially different?
In this case, because they're both non-scarring alopecia, you're going to see some overlap in the direct morphology because you're not going to see follicular loss.
Mhm.
The things in the scalp, with alopecia areata, it's usually just a lot more profound. It's just a lot more active shedding that's going on for a longer period of time. It can be associated with these little bald patches, and so that morphologically is helpful, like really looking for these little areas where there's little tiny round patches, even though the entire scalp has a positive hair pull. But in this case, yeah, you're kind of trying to put all the pieces together.
Got it.
Yeah.
Okay, so that helps me in terms of approaching things. So you said big ticket items, scarring versus non-scarring. When it's scarring, you really are going to have that atrophy, that shininess. You may see active lesions, and you're not going to see follicles, or you're going to be missing follicles. And then you're trying to figure out if it's localized or generalized. So both of these things require a thorough physical exam, getting your patient into a gown, really having a good look. So that's helpful in terms of organizing my thoughts on diagnostics there. Now, maybe we can move on, just moving down the body a little bit, to facial eruptions. So what does the rheumatologist need to know about common facial eruptions?
Oh my goodness. I think, and this is a part where in rheumatology, we have this frame approach. A rash on the cheeks, it's not always a malar rash or a malar rash of lupus. And the other thing that I've learned is that acute skin eruptions from the sun is usually not lupus too. If you get a facial eruption or a rash from the sun, it's not typically a lupus rash. I think the timing is very important there. And then as a rheumatologist, I think it's important for us to know about common skin eruptions on the face that are not related because just taking a step back, in rheumatology, we are mostly lumpers. We like to lump everything in a beautiful diagnosis. And I've learned in dermatology, they're splitters. They say, oh, you have 4 different skin problems.
That's not what I want when I go to the doctor. I don't want 4 new diagnoses before I leave
And
the
4 creams,
yeah.
4 different treatments sometimes.
At
All
least, at
steroid,
least.
but low dose steroid on the face or none.
So maybe we start with what are the common
Yeah.
facial eruptions that rheumatologists need to know so that they can move past those and then get to we can differentiate maybe
Yeah.
some of the light related eruptions because that comes up relatively frequently.
Facial eruption is a really common reason for rheumatologists refer to our clinic. It's interesting because the malar eruption of lupus is actually something that we rarely see. We do see it, there's no question. But by and large, the facial eruptions that we see in our clinic for consultation for facial eruption are other non-rheumatic conditions. The malar eruption is generally a fixed, persistent, infiltrated, sometimes even slightly eroded or weeping eruption on the upper cheeks, as we know, over the bridge of the nose, that classic description. And it's associated with active systemic lupus. So we and so that is the classic malar eruption. Now, at the very beginning, before people are diagnosed potentially with systemic lupus, it could be a fleeting eruption. That's what our textbooks say. And I'm always like, oh, that's frustrating because it could be quite difficult early on. Typically, that's not when we're seeing people. We're seeing them after they've been diagnosed. So what other facial eruptions is the lupus patient going to present with? Facial erythema from rosacea is probably the number one eruption to distinguish from. And rosacea comes in many forms. There's an erythematothelangiotic version, and that's probably the one that's mistaken for a malar eruption most often. And it consists of flat areas of erythema associated with telangiectasias over the medial cheeks, nose, forehead, chin. And it certainly can worsen and get better over time because there are triggers for flushing and erythema. But it's not a persistent, infiltrated plaque disease, typically.
Yeah, and just because you mentioned it, just in terms of the major triggers that you bump into there, is sunlight one of them, or being in the sun? Does that trigger it?
Or wind.
Oh.
Patients with rosacea have very easily irritated skin. So exogenous things like sun, cold environmental exposures, as well as things that are ingested, like alcohol, the classic spicy food, but also, skin irritants from things that people put on their skin as well. Yeah, patients with rosacea are very easily irritated skin. Yeah. Which then brings me to rosacea's cousins, because there are other facial eruptions that are more acneiform that can get mistaken for the malar eruption of lupus because they're red and they can be blotchy and persistent. But the nice thing is something like acne, we have papules and pustules. We typically don't see pustules with the malar eruption of lupus or with a cutaneous lupus, whether it's subacute cutaneous discoid tumid lupus. We typically don't see pustules. So that's when the morphology becomes really important. If I see comedones and nodules and pustules, I'm not going to be thinking about cutaneous lupus. And the other condition that we see a lot is periorificial dermatitis. Perioral, yeah, used to be called perioral. Now we know it's periorificial. And this is exceedingly common. So common, right, Kam? We see it a lot. I call it a cousin of acne and cousin of rosacea. And it's characterized by tiny little micropapules and pustules around the mouth and around the eyes. And it can be scattered over the rest of the face, but it's perificial. And again, the primary lesions are tiny little papules and pustules. So you're not getting violaceous infiltrated plaques. And so it's on the face, and it may even be on the cheeks, and it could even be on the upper cheeks because the malar area of the face is susceptible to all kinds of conditions, not just cutaneous lupus. And so morphology is the key to separating and differentiating all of these.
The other two I think we see a lot of is contact dermatitis, which is often on the face and eyelids, and then seborrheic dermatitis, of course, which is on the nasolabial fold, etc. So I think if we say those are the most common non-lupus facial eruptions.
The one thing that you mentioned was eczematous dermatitis, and eczematous dermatitis is exceedingly common in the entire population. And in fact, a couple of years ago, it was over 10 years ago now, when we looked at the most common conditions that we saw in DART. Remember, eczema and psoriasis were, at that time, at the beginning, probably the most common skin conditions. Probably now, our rheumatologists are so savvy. I actually think we're getting much more true autoimmune rheumatic disease in our clinic because the rooms are very savvy at sorting out the morphology. But eczematous dermatitis, mimicking dermatomyositis, can be tricky because you've got potentially persistent eruption, very itchy on the eyelids. And that's when, again, morphology, like dermatomyositis, tends to be, again, more infiltrated. There's more of a palpability to it, and it is more violaceous and fixed and not improving with topicals. And then you've got eczematous dermatitis, which eczema, as I mentioned, is ill-defined and coalescing and erythematous and can be weepy. And then there may be a history there as well. And so sorting out eczematous dermatitis and dermatomyositis can be tricky. And that's why sometimes we do have to do biopsies, because biopsies can be really helpful in differentiating some of these conundrums.
You've also mentioned, or I think you were getting at, differentiating the polymorphous light eruption from facial lupus rashes. Kam, I think I learned a lot of this from you, but how do you figure that out clinically, that it's more the light eruption rather than a lupus rash? Because legitimately the patient is saying, I get this rash in the sun. And I read that lupus rashes occur in the sun. And you're like, that is absolutely true. So how can you be confident that you're not missing a lupus eruption?
I learned from Sheila that timing is important because these PMLE, polymorphous light eruptions, will happen at the beginning of summer, or if they're in the winter and they're going on a trip and they haven't seen the sun too much as we get in Vancouver here. You're exposed to the sun and you haven't been. But late in the summer it doesn't happen through photo hardening of that. That's one part. And also I'll
Just
pass
for
it over to Dr. Au.
Proud
yeah,
right now.
for listeners, Sheila is crossing her heart lovingly that Kam remembers even one thing that she's taught him. Sorry, Kam, go ahead.
There are times where Tom makes the right diagnosis in the clinic. Sorry to digress, but sometimes he makes the right diagnosis. He goes, this really looks like XYZ. And I'll be like, no, I don't think so. I think we need to biopsy. Then he's right.
Oh,
And then I think, oh my
ah.
gosh, I have to pull something out of the hat to make my presence relevant in this clinic.
Sheila,
It
I
was
get it. When he's right and I'm wrong, it really stings. But the guy's got moves. I don't. He knows what he's
He
doing.
really does.
Yeah.
He really does. I might think halfway between feeling like I'm so proud and why am I here? Yeah.
Like what?
Yeah.
Yeah. When you teach the student as much as you can, I think it's a win-win. Just something clinically. So if we're thinking, is this eczema, atopic dermatitis versus dermatomyositis, we're going to look at the company it keeps. We don't think of, unless if you're super bad on being eczematous, we think of the V-neck in the front and the cape, the shawl like at the back. Obviously, it's easy if they have goitrons, but there are people with atopic dermatitis that, or bad. If your rash is bad enough, I always say it coalesces and you don't really know what the heck it is, especially people washing their hands 100 times a day, healthcare workers, etc. But I think that's where I believe in clinic as a rheumatologist, where my differential is. I think it's fast thinking, right? That you go in, here's the spot diagnosis, and then you're looking for things, I think, to rule out maybe I'm wrong because maybe I couldn't be, maybe I should have thought of something else. So I think that does help us. But obviously, when people are referred to a rheum derm clinic, the classic ones probably aren't there as much. And I think it leads to one thing that is really a bugaboo because I learned nothing about it in med school and now I have to know about it. But lichen planus is seemingly everywhere and common. And Daniel, I don't want to derail your next question, but can we just have a mini lichen planus lecture and how
Yeah.
should we know? Because it's all topical steroids forever, but I think we should know more than that about it.
Lichen planus, big topic. When Tom and I were making a list of some of the hot topics for the podcast, lichen planus was right up there. Was right up there because how do we see lichen planus in the context of our clinic? We know that lichen planus, this skin condition, is lymphocyte driven. It is probably in the realm of an autoimmune condition, and it is associated with other autoimmune conditions, lupus being one of the top conditions. People with lupus are more likely to have lichen planus, and people with lichen planus are more likely to have lupus and other SARDs as well. And there is a lupus lichen planus overlap, and that entity doesn't even have very strict diagnostic criteria. You've just got basically some lupus and some lichen planus in the same patient. We see lichen planus primarily in the scalp, mimicking discoid lupus. We've certainly seen it in the mouth, mimicking other ulcerative diseases of the mouth. We have definitely seen it on the skin, mimicking DM and eczematous dermatitis, because lichen planus and DM, they're both lymphocytic, they're both violaceous in color. They both are associated with significant itch and scale. There are times where there are times where a biopsy is really going to be the only thing that really helps. And the nice thing about biopsy is that we know that the H&E, or a regular biopsy, is not going to tell the difference confidently between the SARDs themselves, like lupus of the skin or dermatomyositis. That's not why we're using the biopsy. But when you have a differential diagnosis that includes lichen planus or psoriasis, eczematous dermatitis, and connective tissue disease, that's when the biopsy can be really helpful, because you're thinking about what else can it be. And we've seen this time and again where patients come in with something called a dermal hypersensitivity syndrome, which is essentially an eruption that's probably in the eczematous realm, but it's very juicy and it's very itchy, and it can be bilateral and symmetric, and it can present in an autoimmune patient, and you think, wow, is this widespread dermatomyositis? And then the biopsy shows classic eczematous sort of features, and it's very reassuring. Lichen planus of the scalp, I've been tricked many times, thinking that the scarring alopecia was lichen planus when it was DLE and vice versa. The way that there are some clinical features that can be helpful. So for discoid lupus, the lesions tend to be very irregular in shape. They're very geographic, and we see a lot of hyper and hypopigmentation. And we may see scarring and dyspigmentation in the conchoboles of the ears or the skin of the face, and that may help. Common things being common, we can try to group these together. Having said that, there are times where the classic lichen planus, which are these oval, scarred, erythematous areas with follicular plugging, I thought that they're 100% lichen planopilaris, and they're classic discoid lupus on biopsies. So
You said two
is the
things.
top one.
Maybe you could clarify lichen planus and lichen planopilaris.
So in planus of the scalp, scarring alopecia of the scalp associated with lichen planus, we tend to call it lichen planopilaris. Pilaris meaning hair. On the body, we tend to say lichen planus. And there are actually so many different types of lichen planus. We've even seen in the clinic, there's a poikilodermatous kind that can mimic dermatomyositis, etc. But the scalp lichen planus comes in several forms. There's the oval, scarred areas that I just mentioned that are often preceded by burning, pain, irritation. We might see at the vertex. There's also frontal fibrosing alopecia, of which there's this sort of epidemic at the moment. It's considered to be part of lichen planus, where the forehead gets very shiny because the frontal hairline is receding in a band, and you've all probably seen this. And then we see these little lonely hairs because there's scarring everywhere, so there's just one little hair that's coming out of one follicle, which is one of the hallmarks of a scarring alopecia is zero hair coming out of a non-existent follicle, or one hair, or a whole bunch of hairs. You should have 2 to 4 hairs coming out of a hair follicle. So too many is too much, and too few is too few. So frontal fibrosing alopecia can have classic lichen planus features in the vertex, and then this frontal fibrosing area at the hairline can also have these papules on the face. And then there's a third one called Graham-Picardy Little, which is associated with lichen planus of the scalp, non-scarring alopecia in the underarms and the groin, and follicular lichen planus on the body. All this to say that lichen planus versus DM is tricky. Thinking about it in the rheumatology clinic is amazing, and you don't have to make that diagnosis in the rheumatology clinic because it is very tricky.
One thing I also learned from Sheila about lichen planus is ask about lichen sclerosis. Do you want to comment on that?
Yes, so a different condition altogether, but one that is something that it's good because we can move on to talking a little bit about morphia. And one of the things that we typically see in patients, or we typically ask in patients with morphia, is about vulvar symptoms. And so thanks for reminding me about that, Kam, because I really wanted to bring that up today. That vulvar symptoms, we can certainly see vulvar lichen planus, the condition we just talked about. So if we see LP of the scalp, we want to talk about LP of the vulvar area. We always want to ask because patients won't necessarily associate the vulva, or in men, the genital area as well, with the skin. Just like patients might not actually associate the scalp with the skin. We want to make sure that people know that the skin involves the scalp, the mucosae, as well as the vulvar and genital areas. And that goes true for lichen planus, where you can actually see Wickham striae, which is this sort of these white reticular changes. You can see ulceration with lichen planus. And then with lichen sclerosus, which is more of a atrophic and fibrosing condition, patients can be exceedingly itchy and have bleeding. And we see that in patients who have fibrosing skin conditions on the skin.
No, I could keep you both here, or all three of you here all day, because I have so much that I want to ask. We may have to invite you back for a second episode, but you did mention that you wanted to comment on morphia. Maybe we can do that as our last item, and then we can leave some really great topics for another time if we can have you back. But what's your beef with morphia? What do rheumatologists get wrong about morphia?
Let's talk to Kam and see what he thinks the
Colin,
When I
what
was
do I get
training,
wrong about morphia?
when I was training, it was not something that we were taught you could help. I was saying you can't really do much about morphia next. And that is so sad because now that I realized how much we see morphia and how morphia can be there in the setting of our other connective tissue diseases and autoimmune diseases.
Can you frame it for our listeners who maybe don't see a ton of morphia? Like, where does it fit in the overall schema of our rheumatic diseases?
I would say it fits under scleroderma, and now we have scleroderma as the overriding as the overall diagnosis. Then we have systemic, and then we have systemic sclerosis, which is our limited and diffuse. So this is not that. So morphia is simply skin involvement of scleroderma. I say, Janet, would you put it there?
I would, and sadly, those with diffuse cutaneous systemic sclerosis or limited can have more morphia plaques. The other way, morphia is not supposed to change lanes and become systemic, but just like lupus patients can have more other autoimmune, they can have that. But where I find it's really discouraging and tricky and very difficult to treat, and you read in the literature about UV, whatever light is popular at the time, A1 or B or whatever, those the profundus ones that are fairly generalized, they often are in their abdomen, but all over the place. They're on their legs, calves, and the front of their legs, their arms, and all over. I must say, I think that is a fate worse than systemic sclerosis when it comes to the skin stuff because it is really like tough, not using a pun, but it is very difficult to treat. It's so deep. And I try it all from regular immune suppressants and topicals or bathing in topicals because it just doesn't make sense, but they're itchy and painful. So sometimes they're putting topicals on places up to and including rituximab and everything in between. And I just find it's really horrible. And I think I see it, even if it's quite rare, I see it because of my interest in scleroderma, systemic sclerosis.
And how about the relations between morphia, deep morphia, and then eosinophilic fasciitis, or they're almost cousins,
They
or
are, and they can
more.
have both. They can have both, and often, and Sheila will correct me in a sec, but often with eosinophilic fasciitis, I find it's a far more treatable condition than deep morphia. But you can have a biopsy that looks like either, and a regular pathologist, if it's deep enough, will actually read it as scleroderma or scleroderma-like conditions. So I think we go by clinical because, again, in a clinic where we're seeing a load of scleroderma, we see lots of eosinophilic fasciitis, and my rule of thumb is it's at least 2 limbs, but should be in general 4. If it's 1 limb, think something else. I don't know, lymphedema. And they have problems with, we'll call it stasis dermatitis-like changes. The ones that are different like that. And then you think there's her hypertrophy, and they can be quite rock hard. And the early eosinophilic fasciitis, pot orange, the river groove, or those kind of signs as well. But I think I should pass it to Sheila because I'm Again, I'm lumping and half splitting because I want to know what treatment am I going to prescribe at the end of this and who else should I refer to? Do you need derm? Do you need physio to get these contractures going, et cetera, et cetera? So that's my modus operandi. So Sheila, you probably contextualize it a little bit differently.
Honestly, I feel like that was perfect. I was enthralled with everything that you just said, and it really resonates with what we
I
see.
kind of made it up from experience. So from experience.
That's our truth. You're speaking our truth of what we see in our clinic too. We see plaques and patches of morphea that are very superficial. They have the classic lilac border. They may have a little bit of, they have some discoloration in the center. And then if morphea goes untreated, it become like scarred essentially. So morphea can cause scarring. And so even the small patches can get really atrophic and have a permanent textural change. So for that reason, I do believe in treating morphea, even when it seems like there's just a few patches and they seem innocuous. I think that we completely agree when we see eosinophilic fasciitis, boy, the patients can be really symptomatic, no movement at all of the ankles, very hard, woody induration. We recently I saw someone who probably had lipodermatosclerosis from venous stasis, and it was just on one side and had more varicosities on that side. So that's venous stasis changes and lipodermatosclerosis, this inverted bottleneck change of venous stasis is part of the differential of EF. But that woody change is so pronounced. And then the patients who have the deep involvement where it goes all the way down to muscle and bone, and everything is so bound down and restricted. Yes, agree that those are the very tough cases. And with EF, I feel like if we can get on top of them, patients quickly, do pulse steroids, get them on treatment, non-steroidal treatment, and follow them, we can
By
get
non-steroidal, she means
Immune
DR.
suppressive, not
sorry,
steroids. Yeah.
no, sorry, not steroids, excuse me, immunosuppression. I feel like we can halt that process.
It seems like it's a cyclical thing. If you catch it on that inflammatory phase with steroids, hit them with some methotrexate, wait it out, withdraw treatment. I think it's the timing, catching it early in the timing. The people that don't do well are
Yeah.
the ones that are missed.
And I've always told the trainees, like, it's easy in a rare disease if you've seen it enough, but it's not so easy for people walking in and saying, I read about it, I'm not really sure, saw it once in my training or something. But it's easy if you see classic. So if they have peripheral eosinophilia on their blood test, that's helpful, but it's certainly not pathognomonic, nor is it essential. And then really, they're often warm when they're quite active. They almost look like a muscular dystrophy calf. It's hypertrophied looking, but the skin on top is tight. We always are getting them to stretch out their arms so we can see the peau d'orange, the groove sign or riverbed sign. I just learned recently they're a bit different, but to me, they're almost the same how they look. So if it looks like your vein has been sewn down or your artery sewn under the other skin, the way you'd have the seam on the end of your jeans, that's actually super helpful. And that peau d'orange look is helpful too. But if you can catch them early, even if you start treating and you're uncertain and you want to go get a biopsy, it has to be deep. It's not going to be pathognomonic because they'll often, the dermatopathologists that don't do it all the time. So I'll say the general pathologist will just read it as scleroderma or scleroderma. So it certainly doesn't rule it out, but treat. Even if you think you need a biopsy, treat so that you won't get them into that phase where they're really very difficult to treat.
And it needs a deep biopsy, not a punch.
Correct.
Yes. Yeah. Deep incisional biopsy. And actually, that brings me to another point that I think is helpful. And I learned this through just trial and error. But when we ask for biopsies for something like eosinophilic fasciitis or for a deep nodule that we suspect is paniculitis or medium vessel vasculitis, we have to be clear as to what layers of the skin we're looking at, we want to look at. And so if we ask for a deep fascial biopsy, we had the experience where our surgeons would give us a fascial biopsy. And they would lift up the skin beautifully and take a fascial biopsy and then close the skin.
Right.
And we realized that we actually needed full thickness biopsies. And so it's like you get what you ask for.
Yeah.
And so I completely understand that we were not asking the question properly. And so now we ask for full thickness skin. So epidermis, dermis, subcutaneous tissue, fascia if we need it, even if you think it's going down to muscle, etc. Then our surgeons are are wonderful at accommodating us for that because, of course, a punch biopsy will never get down to the fascia. And it doesn't even give you a really good sampling of the subcutaneous tissue either.
You two have covered a lot of really interesting content here. I think we'll have to have you back because we have so much more to talk about. Like even just at the end there, Sheila, you mentioned paniculitis versus vasculitis, like
Oh my
nodular
goodness.
lesions. You
Yep.
hinted at some of the oral manifestations of rheumatic diseases. We didn't even specifically talk about psoriasis, and we partially covered mimics. So we have a
Don't
ton.
even get us started on Behçet's disease.
Yeah,
Don't.
absolutely.
That's a difficult one. It is.
So
Yep.
That's somebody else's podcast.
Right.
That's you
Yes.
got to interview
Yes.
someone else for that one, Dan.
Sure. I want to thank you sincerely for all of your thoughtful answers to our questions here and for framing these things in an approachable way for us. If you would, we'll have you back for another episode of What Rheumatologists Get Wrong, and you can...
Or
you-
right occasionally.
That's
What we can
that's a
get
different
even
podcast.
brighter.
Yeah, what we can
Yes.
get righter with
Yeah.
Janet Pope. So thank you both for joining us on this episode of Around the Room.
It was wonderful. I've learned a lot.
So have I. Thank you so much. Thank you, Daniel, for inviting us.
That's it for this episode of Around the Room. Thank you to Dr. Au and Dr. Shojania for joining us on today's episode. For questions, comments, and future episode ideas, email us at info@room.ca. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for all their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes, and share this episode link with your colleagues. It helps more people to find these interviews. Until next time, with Janet Pope, I'm Daniel Ennis. Thanks so much for listening.